Thank you so much. It is a real pleasure to be here and to be able to present today an overview of the current issues in international early child development, really focusing on interventions and the experience of children living in some of the poorest countries in the world. And it's a really exciting time for me as a researcher, as an intervention researcher, for more than 10 years now, working focused primarily in South Asia, but also in East Africa. We're finally seeing some significant shifts in terms of commitments and investments to early childhood development in some of the poorest countries, where earlier the focus had been primarily only on survival. So in this presentation, I'll begin by presenting an overview of the global challenge in early childhood development, and then describe some of the context and the risks that many children living in low and middle income countries are exposed to, followed by describing what are some of the effective interventions that we know have worked in these contexts, and really thinking about why they haven't yet gone to scale. Why are we still at a position where we're talking about very small scale, very expensive programs? And where are the opportunities that we can be leveraging in the coming few years to really make early childhood a much more visible agenda on the policy and programming context in low-income and middle-income countries? So I'm sure that many of you are now familiar with this figure, but in 2007 it was one of the first powerful messages around early childhood development, stating that there are an estimated 200 million children in the first 5 years of life who are failing to fulfill their developmental potential. And this is about 39% of the world's under fives. And really this burden of poor development is concentrated with high numbers in South Asia and in Southern Africa. And in the country where I work, in Pakistan, we have we are one of the 10 countries with the highest burden of children estimated to not be meeting their developmental potential. So why does this matter? Well, really, this is the foundation. And when I look at the education and learning outcomes of young children in the country, we see that about a third of children are not enrolled in primary school. We see that for those that have the opportunity to access primary school, the quality of education they are receiving is poor, where 1 in 6 children are never transferring from grade 1 to grade 2. So we are actually failing young children at a very early point in their life trajectory. And if you manage to succeed, the quality of the learning that you graduate from, whether it's primary school graduation or higher, is poor. And at the national level, Pakistan is ranking as one of the countries with the lowest literacy rates in the world. And really, we believe that if we are able to start promoting some of that early development, some of that learning from birth before children enter school, so that they are more ready and their families are more ready and the schools are more ready, we may be doing a better job. But one of the problems we face is that we have no real measure of the actual situation of child development across the globe. So we're relying on 2 proxy indicators of poverty and stunting. So this is where the 200 million figure comes from. In reality, it may be a lot higher, but we're simply not collecting national or population level data that gives us a clear and more precise picture of what is happening to children in those first few years of life. So the association between poverty and child development is perhaps a little more well established internationally, but what do we mean by stunting? Well, stunting is really a measure of moderate to severe low height for age. And this is measured against a growth curve that is standardized in a global context. So it's children that are falling 2 standard deviations below these international growth curves. And it's really an indicator of chronic undernutrition that establishes early on in life. So it begins to establish from pregnancy, where the mother is undernourished, so the child or the infant is not going to be growing well. We have significantly higher rates of low birth weight and children who are small for gestational age. So this picture simply illustrates stunting. You have two children around 2.5, same age, but one who is significantly shorter. And this is not genetic growth shortness. This is directly a consequence of undernutrition from a very early point in life. And what we know, if we look at growth filtering trends from across 54 countries, and it's this lower line that we're interested in, we can see that your growth trajectory tends to fall. Your height for age tends to decrease, and that lowest peak is around 22, 24 months of age. So by 2 years of age, we can say whether a child is stunted or not. Why is this important? Well, 24% of the world's under 5s are stunted, and again, a similar geography where you have greater stunting in South Asia and in Southern Africa. But among stunted children, if you look at, for example, the context of Guatemala, 40% of these children are going to be failing in grade 1. So there is some association between stunting and learning outcomes, educational outcomes, and future adult productivity. While the biological mechanisms are still, they still need to be elucidated, we know that there is some association. And this is really one of the indicators we use because we don't have anything better at national level. Again, in longitudinal studies where children with early stunting by 2 years have been followed up, we are clearly seeing cognitive and schooling deficits. And this is data that shows deviation in cognition and school achievements from the Philippines, South Africa, Indonesia, Brazil, Peru, and Jamaica. So these inequalities in a young child's developmental trajectory are established very early on in life, and risk factors such as poverty, such as stunting, when outweighing the protective factors, we're going to see a poorer developmental trajectory from prenatally through to adulthood, compared with where we see protective factors allowing for more optimal developmental trajectories, shown by the upper green line. But there is an opportunity there for closing those disparities through early intervention by improving the developmental trajectories, by addressing some of those risk factors, by trying to mitigate them. So, as an example, we can see that these inequalities are not only seen between high-income countries and middle-income countries and low-income countries, but we can see them within the population. So this is UNICEF data, and it basically shows children under 5 years of age with access to 3 or more picture books. And what we see is, generally in low-income countries, very low access to something as simple as a picture book. But if you look at, for example, Vietnam, here you see in the light blue bar, the wealthiest groups within the population, maybe 70% have access to picture books, whereas the poorest quintile, the lower 20%, there's less than 10% of households that have access to picture books. Even if you look at a slightly wealthier country like Serbia, among the wealthier households, maybe there's around 90% of households with access to picture books for young children. But again, the disparity is significant when you look at the poorest groups, with just over 50% with access. So having access to basic learning materials is a major challenge. And again, we can see this in pre-primary learning, where, just taking one example from Cameroon, you can see that among the poorest quintile, only 4% of households are able to access some kind of early education service. Even when you look at the wealthiest, you're still only looking at 55%. So there's a lot of scope where we not only need to improve access, but also quality to what services children are receiving in these early years. So beyond stunting, beyond poverty, what are some of the specific risk exposures for children growing up in low and middle income settings? We know that these are going to be contextualized by social determinants, including maternal empowerment, including gender equality. Pakistan, for example, has some of the highest disparities between girls and boys, and that can be visible from as young as infancy. You can see the differences in the way children are fed, you can see the differences in what investments are made between girls and boys, as well as access to services. So you're seeing both psychosocial risks and biological risks that are then influencing child development, early learning, and eventual school performance and adult productivity, and of course the intergenerational transmission of learning and development. So in terms of biological risks, the three that are most prominent are all related to poor nutrition. This includes stunting and the indicator of chronic undernutrition, iodine deficiency, and iron deficiency anemia. In addition, we know that we have evidence around low birth weight and growth restriction in the growing infant, malaria, which is still prevalent in many parts of the world, diarrheal disease, which across South Asia, in India, in Bangladesh, in Pakistan, is still one of the top 5 killers for children in their first 5 years of life. HIV infection, particularly in Southern Africa, and of course environmental exposures such as lead. We've had less focus on some of the psychosocial risk factors. These include inadequate stimulation or the learning environment that children are growing up in, poor quality of parent-child interactions or responsive parenting, maternal depression, which is something that only very recently has started receiving attention on the global agenda. Institutional care is still prevalent, as well as exposure to violence. And here we're looking at both domestic violence that children may be exposed to, may be observing, may be victims of, as well as violence in their environment, in their context. So if we're taking the 4 risk factors highlighted in red, these really affect up to 1/4 of all children in low and middle income countries. So it's no small number. So how does nutrition affect children's development? It can be through multiple pathways. A child that is repeatedly sick, has repeated episodes of diarrhea infection, is poorly treated in terms of the medication or the intervention for diarrheal treatment, is going to deplete in their nutrients. That's going to impact on their physical growth, but also on their activity, how much they're going to be active, how much they're going to explore, how much they're going to engage with their environment. That is going to also potentially affect the way that the parent responds to or picks up signals from their young child. And eventually, that's going to affect the child's cognitive, social, emotional, and motor functioning. When we look at lack of stimulation, this is an issue that's really been only picked up over the last few years. It's more recent on the international agenda, if you like. So surveys indicate that only between 10 to 41% of households in the poorest countries are providing play or toys, early learning materials or stimulation materials. And only 11 to 33% of parents really talk about being involved in play with their young children. So these are stark figures. And often the household may have things that children can play with, but are perhaps not being optimally used because everything becomes a precious resource. It is not something for children for children to explore. And a typical environment that I see in my context, and that's typical across some of the places that I've worked, is having an environment where children can't freely explore, full of hazards, full of risks to illness, which stops that exploration from happening. So again, we know that if children are not having the provision of the materials, they're not being engaged by the adult in terms of communication, in terms of encouragement to explore, to problem solve, we're again going to see this impact on early development pathways for cognition, for language, for sensory and motor functioning. The other risk factor that I think is very closely linked is the mother's emotional availability or maternal depression prevalence. And both the prevalence during pregnancy at around 16% and postpartum at around 20% in low and middle income countries is higher than what systematic reviews have reported in high income countries. And there have been associations to do with lack of maternal autonomy or lack of empowerment, lack of freedom of movement among women, lack of family planning. The more children you have to care for, the more children you're delivering is going to exhaust you physically as well as mentally. So there are a number of risk factors which are perhaps more prominent, more visible in the lower income context. Importantly, in South Asia, a risk factor for depression that's highlighted that perhaps isn't visible in other regions is having a girl child. Because of the value placed on having a boy child, if the mother delivers a girl, that's seen as her fault. And there's a lot of pressure as a result on her for not having done the right thing. So when we look at maternal depression, this isn't just important for some of the things that we may be interested in around children's cognitive outcomes or language outcomes. We see that it affects uptake of prenatal care. We see that it results in less breastfeeding, and in a context where you may not have access to clean water, breastfeeding is an incredibly powerful protective factor, not only for a child's development, but for a child's survival. And so having early cessation of breastfeeding becomes problematic across that survival and thriving intersection. We see that it's associated with child undernutrition, inadequate attentiveness towards early signs of illness, as well as lower responsive parenting, and evidence emerging around harsher discipline from the low-income context as well. There are studies that have explored this, and more are emerging in the recent literature, but these simply show that the risk of having an underweight child is 2.3 to 4 times higher if the child has a mother who has been diagnosed as depressed. And the risk for increased episodes of diarrheal illness is 2.3 times higher if the mother has a diagnosis of depression. So this cuts across the health, survival, and the thriving of a young child. And of course, a child isn't going to be exposed to one risk factor. In an environment of multiple disadvantage, these risks will accumulate over time, they'll co-occur. But there hasn't been a lot of evidence in trying to really model risks and model what is happening from the low-income context. And so this is from, I think, Guatemala, and it's simply showing that as the number of risk factors increase from 0 to 8, you're going to see a decreasing trend in children's knowledge acquisition, their academic achievement, their numeracy skills. So putting the pieces together, and this is kind of a broad brush, and there are nuances within this, but having a baby that is having a mother with lower emotional availability because of stress, because of depression, and it's important to remember that postpartum depression isn't for a few weeks post-delivery. It can be 12 months, the first year of life for a young infant. A mother may not pick up on the signals of a baby that is repeatedly sick or of a baby that is undernourished, who may not be crying, who may not be demanding for attention, who may not be exploring, and that child is also competing with siblings that may be healthier and demanding attention. So while there are, I think, more nuances to this, this is a kind of broad brush on what could be happening in an environment where you have multiple risks. So moving forward, how do we start to address this? Are there effective interventions to promote children's development in low and middle income countries? So we know that we want to begin early, and by early, people are really thinking about the mother's preconception health. Can we really focus on birth spacing to promote a mother's nutritional health, as well as her physical and mental health? And really focusing in the first instance, the first 1,000 days, and looking at optimizing infant and young child feeding, looking at optimizing early care that cuts across growth, health, as well as development, as well as promoting the foundation of stimulation. But really not stopping here. And this, as a sidebar, has been a real problem, I think, in the disciplines of having the traditional public health community meet with child development, and with the nutrition community very much focused on the 1,000 days, and as the child of a global child development community, us leveraging on that opportunity, but really trying to argue the case and find space for the importance of going beyond 1,000 days, that development isn't going to stop, that you need support in other sensitive periods, such as transition periods as you're going from home to school. Importantly, in our context, really making sure there are stable transitions in those early years where we're seeing the highest number of children fail in primary school, grades 1 and 2. And again, looking at revisiting this in adolescence, where you have other sensitive windows of opportunity that will eventually impact on children's development in the next generation. So it's a multi-sectoral issue. It's about health meeting education, meeting social protection. And this is a busy slide, but really all it's saying is that in the top layer, in the pink and red, we're seeing in the very early years a larger role for the health sector, which as you transition from 3, 4, 5 onwards, you're seeing in the yellow bar the education sector take more of a responsibility, take more of a role. And of course the challenge for us at national levels is, how do we coordinate this? How do we ensure that these sectors are speaking to one another, that there is coordination, that there is consistency of messaging, and we're expecting someone to have ownership. One of the challenges that I've had in Pakistan when I first started working there in 2008 was it took a year for us to convince the government that ECD was a health sector responsibility. Every time we sought permission to work with health workers in the government sector, we were thrown out and asked to visit the education sector. So the message is still taking time to get through, to translate what we now have good evidence about into how do we really communicate this in different contexts around the world. So we know that it's important to combine packages of care. We know that it's important that these interventions are sensitive to families and caregivers, particularly mothers, but that they're also child-directed. We need to know that households have access to food for all the nutrition education that you promote. It will fail if you do not have household food security. We need to know that children have access to appropriate treatment when they're sick. And we need to know that families have literacy in health and nutrition, that they are aware of the linkages between the value of good health, the value of good nutrition, and how it links with a child's thriving. We need to know that mothers are supported, that they're not only physically healthy, where the focus has been in recent years, but we start thinking about their mental health as well, and that there's stability in families, so that we can really promote responsive caregiving and interactions. We need to then ensure that we also have enriched early learning environments, clean and safe places for exploration, and opportunities to promote early development and encourage relationships, not just interactions, which are a moment in time, but really a continuum of caregiver-child relationships. So this is an old study, but I think it's important to flag for a number of reasons. Within the low and middle income country context, this was a landmark piece of work. The Jamaica study was published in 1991, and it was really one of the first studies that highlighted that alongside nutrition, children needed stimulation to promote their development. Up until this point, really the focus had only been on nutrition interventions. And so what Sally McGregor and colleagues in Jamaica did was take children at 6 to 9 months of age, provide either a stimulation intervention, which was essentially a weekly home visiting program, looking at training or working with children for developmentally appropriate activities. Another group received food supplementation on a weekly basis. Another group received the combined enriched package. And these children were followed over 2 years. And we see that compared with the control group that received no intervention, that stimulation was really doing a good job, significantly more than nutrition alone, in promoting children's development. But that there was an additive benefit when you combined the two interventions together. And you could start to see some catch up to the healthy comparison who were not malnourished in the first instance. However, this is where there's a note of caution. Since this study in the 20 years that have passed, we cannot simply say that means every combination that we've tried has resulted in additive or synergistic benefits on children's development. I think I can highlight 3 to 4 studies in the literature, one from Colombia, one from Guatemala, that have shown, and another one from Jamaica, which have shown some additive and synergistic effects. This doesn't mean to me that we shouldn't be combining interventions. I think there are multiple reasons to do so, and I think that we also need to start looking at how we can optimize that partnership better. How can we synergize these two interventions? Where are we failing to really realign the nutrition agenda with the child development agenda? So, other good reasons for combining the packages is they're addressing common risks. If children are undernourished, if children are continually sick, if a mother's depressed, it is going to affect your pathway to your learning outcomes, it's going to affect your pathways to your physical health outcomes. So we also want to ensure that we're efficiently using our resources. Most countries cannot set up separate child development programs. We're going to rely on one service provider to provide combined messages. And really it's going to be more practical for families to have a whole child message. The challenge is how many messages, how do we ensure there's a balance across those messages, and that they're consistent across that time span. So we know that health and nutrition are necessary for children's development, but we know that they're not sufficient alone. And we know that it has been a challenge to integrate stimulation into health services. And partly that's because where the policy has been. The policy focus, the national indicators have been on survival. And that makes sense historically. When you think of Pakistan, about 500,000 children die in the first 5 years of life. These are unnecessary preventable deaths, and Pakistan ranks 8th in the number globally in the countries with the highest burden of under 5's mortality. So to put simply, for every 1,000 children that are born, 100 will not see their 5th birthday. 80 will die in the first year of life. 50 will not make the first month of life. 30 will die in the first week, and the majority of those will be in the first day, in the first 24 hours of life. Globally, since early 2000, when there was the child survival revolution, we've seen a shift. We've reduced numbers from 10 million preventable deaths in the first 5 years of life to now just under 7 million. That has paved the way for discussion around bringing the two agendas together. Not to say that we need to stop the survival agenda, we have to pursue it. 7 million deaths is unnecessary deaths. So trying to build curriculum that can be used in a number of different contexts that are simple enough to be taken up by service providers. For example, in my context, I'm working with service providers that have between 6 and 8 years of formal education. Many are community health workers, depending on the country that you're working in. They are either paid or not paid. So the more interventions you add to their agenda, the more you need to think about what are their motivators to deliver them. So this is one effort by UNICEF and the World Health Organization to have a simple enough curriculum that will provide ways in which community health workers can deliver messages about promoting a variety of stimulation in the first 5 years of life, alongside their health and nutrition services. We have contextualized this intervention, and in many ways it requires a lot of adaptation. It isn't enough to provide a health worker with 6 years of education to say, here are the ways that a 12-month to 2-year-old can be introduced to a variety of stimulation that will promote ever more complex skill building. They need to be broken down to more concrete pieces of advice, more concrete pieces of examples, because these women who are delivering the interventions are coming from the same communities. They've never been able to do this with their own children, yet alone advise another group. So I think there are still a lot of lessons that we need to learn about how we deliver interventions that on the surface look simplistic but are actually quite complex to have quality training in. They rely on low-cost resources. Some of it is building communication skills between young children. Some of it is trying to optimize everyday materials found in households, like cups for stacking. And some of it is trying to create low-cost toys that can be homemade. Again, the challenge is a family may be able to provide low-cost toys. Making a rattle out of a plastic bottle with pebbles could be fairly easy for an infant. It becomes harder as your child transitions from 2 to 3 years of age, when you don't have access to picture books. You don't have access to magazines where you can cut out pictures and talk about them. So that means that we really need to think about other innovations, mobile libraries, mobile toy libraries, exchanges, but how do we really make this accessible and sustainable? The promotion of, this is from one of our studies, the promotion of shared reading was a particular challenge, and we found that the only way we could do this was to provide picture books. What was interesting was these picture books were targeting children in the first 2 years of life, but the 4-year-old in the household, the 6-year-old in the household, the 7-year-old in the household had never had access to a picture book either. So it became an incredibly precious resource that was used across age groups. And so having some thinking about there's never going to be one child in the family. The mother's not got to be thinking just about the case child that we're interested in, but how does she build those lessons and apply them for all her children. So in this video, what we're really seeing is a mother that had been exposed to an early childhood development intervention and seeing some of the skills that she had been able to pick up in terms of exploring things with her child. You know, while there may be scope for improving that interaction, this was definitely a difference from where that family had begun. And you could see that even in some of the most challenging circumstances, this is a skill set that families valued. The idea of, I think a lot of our qualitative research, which supported the quantitative, was really talking about how mothers perceive the intervention and a sense of empowerment, of being able to see that there was something that you or she, as a mother, could control for her child, that she could give to her child, which didn't depend upon, communication itself didn't depend upon whether there was food availability, a decision from her husband or her in-laws, but something that she could do on her own. And that in itself is a motivator for sustaining or adopting some of these practices. Now, when we look analytically at this is a meta-analysis, which was taking the studies, which are still not as much as we would like to see in terms of the number of studies which have done early childhood stimulation interventions in low and middle income countries. So these studies range from largely from Jamaica. The next highest group came from Bangladesh. We then had India, Pakistan, I think Chile, and Indonesia, and Uganda. So basically we can see the effect size, and the overall effect size on cognitive outcome was 0.42. So it's on the lower side, it's the moderate sort of effect size. Language, when we analysed it, and this is a paper in the Annual Review of Psychology for 2015, so we've also looked at language outcomes there, and it's about 0.62, so it's a little bit higher for language outcomes. So one of the challenges is trying to understand what went on in those interventions. So people are reporting the outcomes, but we're really not getting much of a picture in terms of what was the theory of change that went into those interventions, how were they implemented, and what lessons could we tease out from more effective interventions and less effective interventions. So some of the techniques of behavioural change that made interventions more successful. And so these were trying to, in some way, look at what was provided in terms of the counselling strategy or in terms of what was physically provided to families, and looking at that with the outcomes. Small media, things like having the families have prompts at home, like leaflets or illustrated calendars or posters with play activities, had a good association. Performance-based. So this was studies which reported moving away from a more traditional didactic approach of counselling, where they were just giving messages, sort of using a traditional form of adult education, to having mothers actually try out the activities and being coached, so getting them to experience a successful interaction. There was some association there. Where people had reported problem solving, so that the health worker or the ECD worker, whoever that might have been, was discussing with families how they could address the challenges they were facing in implementing interventions. And that could have been from anything from a lack of time to my child is not responding to I don't know how to provide these play materials. Social support. Now this is a technique that has been highlighted in some of the recent papers, but really far too infrequently to assess its value. So this could include using group-based strategies so that mothers have peer-to-peer support, engaging rather than just the mother alone, but engaging the family as a whole, particularly where decision making is not in the hands of the mother. So engaging both parents, having greater father involvement, having greater mother-in-law involvement. The provision of materials, this was low, a little bit lower than the others. And really it's partly because if this was the only thing that was done, if you just went in and like a book library and provided the materials, but really didn't combine that with any experience of how to use them, how to optimize interaction, that wasn't going to be effective. The studies that reported using multiple techniques did a little better. The challenge was across 34 studies, we found it very difficult to get any information about what was actually done. So we were trying to tease out what was actually done in terms of how was this intervention delivered, what was the compliance, how much training was given, how did families accept this intervention, what was the intensity, what was the duration. These things are simply not adequately reported. And if we want to move the science forward, we really need to be thinking about how the implementation features mediate some of those outcomes. So this was a major challenge and something that we really needed to flag. So some of the lessons that we were really trying to tease out that we're getting some information about is intensity. The greater the number of contacts between service provider and family and child, the better the outcomes. Having said that, there's only one study that's formally addressed this question. So in the 30-odd studies, we know that a 2-weekly, a fortnightly visit is going to be better than a monthly visit. But that's not going to be feasible. In contexts where a health worker is looking after 1,000 population, it's more likely to be every 2-month visit. So how are you going to build in intensity in that very real scenario? The other thing that we've looked at is where described, if people have used mixed delivery strategies, so home visits combined with group meetings. Trying to explain that, I think that you're achieving different outcomes. I think groups are about changing attitudes, about creating community demand for something, about engaging peer support or peer-to-peer learning. So I think it has a value. It is also in contexts where women are not able to leave the household. Early child development is a non-taboo subject. You can go to a group session, you can engage outside of the household around it. Whereas I think the home visiting is much more personalised to that individual family and child. We know that interventions which have been skills-based, really promoting the practical experience of parents, have tended to be more successful. We know also in the same vein that intervention training, which has been more competency-based rather than just knowledge-based for health providers, has been more successful. It is not enough to inform care providers, whether they're health workers, whether they're child protection officers, about what messages to give. They need to experience those themselves. They need to observe enough mother and child interactions to know how are you going to coach. And from our experience, videos didn't work. We really needed to get them to see enough and really know this is the point where I can prompt. Coaching is a complex skill and it evolves over time. And we know that including the most disadvantaged children, they're the ones that had the most benefits. So this is from some work we've recently completed, where you can see that the number of risks that the child is exposed to ranging from 0 to 6. And these risks include having a mother who is depressed, coming from a household where there's food insecurity. You can see in the red, green and the orange lines that the cognitive, language and motor development decreases in terms of the score at 2 years of age. And this is the population average for our study cohort. The children that have been exposed to stimulation intervention, shown by the dashed line, there is some protection. They have a little bit of higher developmental scores. So we know that at some level the ECD intervention is protecting children in an environment of high risk. We know that we need to, when we think about the sheer numbers of children that we need to reach and the sheer numbers of families that we need to reach, that we need to look at beyond simply home visits and group strategies to think about what are we learning from media and technology innovations and what can we learn as lessons from high income contexts that can be applicable. So for example, Sesame Street has been adapted in a number of countries. And in addition to showing some learning development gains, we're also seeing changes in peer relations in children in values like tolerance. So in South Africa, there is one of the puppets who is HIV positive. So really educating very young children about the importance of not being discriminating. In Bangladesh, one of the girl puppets is a very assertive, very empowered character. And again, it's sending out a message. And so being able to go beyond some of the traditional outcomes we're measuring is very important. Newer studies are looking at mobile phone technologies. I think that's great, that may be great for improving awareness and messaging. I also think that in some countries it may be an important way to reach fathers, because while we see a huge number of mobile phones in households, who handles the phone is still the father in some of the communities that we're working in. So if he's receiving and he's seeing those messages, that in itself may be an important lever for us to take advantage of. But again, these things haven't been robustly evaluated as yet. We're getting more evidence. The picture is still emerging. We need to ensure that we also maintain those early gains in the first 3 to 5 years of life so that children can access preschools, and that they are of reasonable quality. About 88 million children around the world drop out of primary school. But we know that for children who have access to at least 1 year of a pre-primary program are more likely to go on to complete the primary school education and have greater educational achievement. But there are challenges. Having access alone is not enough. So these are photographs from our district. And you can see that these are the Gachi class or the pre-primary class. Often they're part of multi-grade settings, so the youngest children are sitting in with grade 1 and grade 2 children. The attention is going to be focused on the grade 1 and grade 2 children, not on the youngest. The setup you can see is it's not encouraging learning through play. It's not encouraging sort of child-centered learning. We still observe a lot of dictation. We still observe a lot of kind of rote learning. In some instances, the youngest children, both the preschool children as well as grade 1, get the poorest space in the school, so they may be the ones sitting outside. And again, we see limited resources, so it isn't enough to just provide the classroom. That's also going to encourage dropout. If families don't really see any academic gain, academic benefit, they're not going to send their children to preschools. If they enroll them, there's not going to be any motivation to ensure that they go. The Lancet series in 2011 estimated that if globally we could increase preschool enrollment from about 25 to 50% around the world, we'd increase substantial returns financially between $11 to $34 billion. And that's a benefit to cost ratio of between 6.4 to 17.1, depending upon where that percentage enrollment is increased. So over the last 30 years, why are we not seeing that significant shift? And here I'm talking about a significant shift, not just in terms of policy or practice, but also in terms of international research. Why are we not seeing more studies coming out of these parts of the world? So historically, as I mentioned in my introduction, there's very little attention on child development. It was basically focused on child survival. And we can see that there are some critical changes. The 12 Who Survive was a landmark piece of work in trying to focus attention on what happens to children who survive, what are their life trajectories like. In the Millennium Development Goals, it really pushed countries into thinking about cutting malnutrition by half, which is important because that's a major risk factor for child development. But this quest for a child development goal was never included. And that influences where people are going to invest in their national programs. And really, we are now at a point approaching 2015 where there is a potential to have an early child development goal. But we are competing with 115 other goals. So whether it makes that final cut in the next 2 to 3 months is going to be significant. But whatever the final indicators look like, which ones can we use and really say, these are the ones that can be our composite, that can help us to track. So how can we take advantage of the indicators that are shortlisted and say, these are going to be a better set of proxy indicators than just relying on poverty and stunting alone. In terms of challenges, we need to build capacity to provide high-quality ECD programs. So while some efficacy studies have provided great impact, great effect sizes, as we've moved on to effectiveness trials and operational studies within real programmatic systems, we're not seeing those same impacts. We're not seeing enough expertise being developed in the lowest income countries to really promote the child development agenda. We also need to build the local evidence base. In South Asia, for example, it isn't even enough for me to show a successful example from Bangladesh and its application in Pakistan. The policymakers want to see, will it work in Pakistan? And so we need to build those local stories, those local case studies with robust and well-measured interventions. And we need to improve measurement at all levels. We need to see what is feasible to measure at the national level that can be incorporated into census or household level data. UNICEF Mix has an ECD module, but it's been used for 3 rounds. It is still an optional module, so not all countries will integrate it into their surveys. Having said that, most children are hitting ceiling when it comes to the milestones that have been selected. And so there is an exercise underway, a partnership between the World Health Organization, UNICEF and UNESCO, really looking at what can be the new generation of indicators that are reliable, that are valid, and that are feasible, that you can measure with data collectors at household level. But also, I think we need to have more measurement on these children's developmental trajectories. They have very different contexts, so we can't rely on research from 10% of the world's population and extrapolate to 90% of the world's children. So we really have limited data here. But I think there are opportunities. We're seeing increasing number of countries with national ECD policies. We're seeing world leaders express their commitment. So Chile is an example, Rwanda is an example. We're seeing opportunities in the global funding. The Clinton Global Initiative has really taken a focus on early childhood development, as has Grand Challenges Canada, really focusing on investment in the child development agenda, which is new. That's very recent. We need to have equity from the start. We can't do that without focusing on early childhood and having access for all children, regardless of their ability to pay. And I think this is really now the time for us to leverage those opportunities in the global landscape and think about collaborations that can promote the expertise from the basic sciences around development and operational work that's going on in low and middle income countries. But those collaborations have to promote local capacity. They have to ensure that eventually those questions are driven from the local context. So children in low and middle income countries are exposed to multiple risks for their survival and for the development. We know we want to address this early in order to tackle lifelong inequities. We know that early intervention is critical. We know we need to target the most vulnerable children, and we need to begin this in the first 3 years of life, but continue. We need to focus on the implementation science piece. If we're going to go to scale, we need to ensure that those scarce resources, that those dollars are invested in the right programs. We need to build a local evidence and body of expertise, and we need to support the intervention agenda with a high quality agenda on understanding measurement around child development in these contexts. So in closing, I just want to acknowledge that that our child development program has a very small team, but a very committed team at the Aga Khan University, but I have a host of collaborators from around the world, including here at Stanford with my colleagues at the Spark Lab. Thank you so much.
So we do have some time for questions. If anyone wants to stick around before we join Aisha for the reception outside, so please feel free to ask any questions that you may have.
You touched briefly on mobile technology. I'm wondering what else you see that has potential to, I guess I'm thinking specifically of relieving some of the burden on the community health workers, both in terms of access, also in terms of the sheer amount of things they need to do in information transmission.
So there's a couple of things that are being tried. The one area where I think that mobile technology can really be leverage and support the health worker, the community health worker in terms of burden of work, is using it as an effective monitoring tool. So having prompts for, okay, so here's a child that is clearly having risk for undernutrition, or is dropping in their weight, or is not meeting their developmental milestones. These are the children that need to be revisited, so that if she can start to target households, she can't everyone. But it's difficult for her to manage that workload, and I think this is where technology can be leveraged, and we know that some of this is being tried at scale with community health workers in Kenya, for example. Outside of the health sector, in the education sector, the Bridge International Academy in Kenya is looking at laptops, providing laptops to primary school children, as well as to now pre-primary school children. And they've reached 100,000, and it's really trying to provide educators with a standardized curriculum for the early years. They have shown some benefits to educational outcomes. We need to think for the youngest children how much that technology can facilitate interaction and not really so we don't want to lose that for the youngest children, the teacher and young child interaction piece. So how can technology facilitate and enable that and complement it rather than be the prime piece that's leading the education? So there are a few different innovations that are being tried across sectors, and I think that they're showing promising results, but they're largely being tried in a limited number of countries. So we're largely seeing this come out of Central Asia and East Africa at the moment.
In this country now, there's a growing interest in this, and I was at a conference at the White House last Thursday that put together federal leaders and media people from NPR and PBS and so forth, and foundation heads and so forth, and one major approach is this information dissemination on a massive scale, like the Amazon, Jeff Bezos' room. I don't know if you're familiar with that. It's the thing that buzzes in your cell phone every day to give you another brain building tip and so forth. The Clinton Foundation has given a lot of resources to Too Small to Fail, which is an initiative also aimed at billboards in Oakland, signs on diapers actually, as well as signs on bus stops, wonder how you think about is the sheer power of that kind of information, which is easier to scale.
Yeah. So I think there is a lot more debate now about how we gain traction how we gain traction nationally in raising the visibility of early childhood development, and thinking about it not only being a top-down approach from policy to grassroots, but creating demand and pushing the demand side. And I think to some extent, if strategies like this can help create a public demand for child development services, that's good. And even if that demand is coming from the more urbanized or the more middle income communities, it's raising the profile nationally as a whole. The challenge then becomes, I think, very much for the communities that I'm working in, the poorest, that may become aware but not necessarily know how do you harness that demand. So once you've created that awareness, how do we optimize on it to really push that policy and investment and commitment agenda? So I think there's scope for it to be effective in creating awareness and getting visibility, but I think we still need to think about that missing link about how among the poorest communities, if you've created some awareness, how do you get people, or how do you facilitate the harnessing and access to services at the other side of it? Because even in small studies, you've got to a point where we've gone through 0 to 3, and families are saying, well, what next? Because there isn't access to anything next, and so that is demotivating.
I just want to commend you for the work that you're doing. It sounds both very challenging and very good. You may have addressed this in your first part of your lecture, but as I was listening to you, I was wondering, is there any research that is following children who are, and families who are in a developing nation but then are emigrating to other countries where there may be more universal both pre-primary and primary education. Obviously here in this country we don't have at this point in time universal pre-primary, but we do have universal primary for most children anyway.
So I am sure there must be, there's more literature about that within the US, perhaps looking at the diverse populations and immigrant or migrant populations, but I personally don't know of studies, for example, where children have been tracked who have made that move. Certainly, at least coming from the UK, I'm not familiar with that in the UK literature, but others might be more aware.
It's commendable to see this kind of research coming out of Pakistan. And while some of the changes that you talked about, the maternal depression and the importance of being a child are going to be generational over time, I'm wondering what your experience has been in the buy-in that a male leader of the household or the caregiver has to have if any of this to take place.
So this is not from my research, this is from Professor Additive, who's at the University of Liverpool and has a field site in northern Pakistan. So one of the intervention strategies that his group has used is the Thinking Healthy program, which is really using, I think he describes as its principles of cognitive-based therapy to work with the mother to think about how she can tackle child care, child health, child nutrition, child development challenges to promote more optimal care. And the idea is that the lady health worker, who traditionally has really only targeted the women in the household, to engage with the family unit as a whole, including the father. And what he has reported as because the child is a common agenda, you can increase paternal support as a caregiver. So for example, if the challenge for the mother has been not having enough rest during pregnancy, the agenda of the child, the health and the future well-being of the child becomes significantly important for that father. And so while it is unfortunate to say it's not directly about supporting the mother often, but through the common agenda of the child, you can engage the father. And so there are approaches which are specifically trying to do that and have had some success. In our recent trial, over the 3-year period, over the 4-year period that we were running the RCT, we had 2 seasons of quite devastating floods in the province, in the district. And what we found was when these interventions then moved to the IDP, internally displaced population, camps that were in the schools, we actually found that it was easier to target the fathers. The health visitors were continuing their work in the schools, visiting families that were taking refuge there. And really, that was when we first saw father engagement with learning activities, with picture books, and and I think there can be more, and their value on it. You know, this is something that they felt was important. They valued the idea of their child learning and being able to do something about it. I think the challenge then becomes, in a typical situation, how in the context of our country do we really reach the father? Because the health visitor is not typically going to do that. She's going to be working with other women. But I think we have promising avenues through the work in Punjab and other regions in the country.
Thank you for your presentation. That's very interesting. And so you're mostly talking about home visits, if I understand correctly. I'm wondering if, I know in Jamaica, for example, they attempted to integrate the health and stimulation component by offering the service at health clinics, and then some other countries, I think, have done kind of community groups. I'm wondering what you think about the potential with those models, or if you've seen them in different contexts.
So the majority have been home visits. I think even in Jamaica, they've been clustered around the health centre, but the health worker has gone to make the visits in the home. Ours was a combined. France's Aboud has done or looked at mixed methods where they've done groups and home. And what we're starting to see is different outcomes perhaps being associated with the different strategies. So France's Aboud's work, which was published last year in Social Science and Medicine, showed that the women who participated more frequently in group sessions had decreased maternal depressive symptoms. So it may be something about providing peer support and social support that enhances emotional availability from the caregiver's perspective. So there may be different things that you're harnessing through those different strategies.
You mentioned that what a problem it was that the Ministry of Health was in one silo and the Ministry of Education was in another. Do you see any change in that? I mean, you also mentioned that there has to be a good preschool waiting for that child who can move the dial a bit on his child's potential, meeting his potential, but he goes into a really poor quality preschool, in which case he's not going to last that game. That's one way in which they need to be linked. And another one has to do with adult literacy, because of course that's one of the biggest predictors of better outcomes for children at every level. So ideally they'd be talking to each other. Is there any hope that will happen?
So I think, if I move outside of the context of Pakistan, I'm also working in Rwanda, and as a model, what's being done in Rwanda is that there are targets within the health sector, targets for early childhood development in the education sector, but what they have is a national planning strategy on ECD. So And interestingly, it's housed in a ministry which is quite powerful. And that's also important. I think if you are going to go down the route where you have a coordination strategy, if child development is housed in the Ministry of Sports and Social Welfare or gender, it's a less powerful ministry. But if the coordination is led within the Education Ministry or the Health Ministry, but there is an onus on them to make sure this coordination happens, that there are meetings, that they know that these set of indicators that you're going to achieve within one term of power are going to be depending on each other, I think it's more important to think where that national planning strategy works. It's early days in Rwanda, but there are a number of countries that have tried it. Each country has slightly different political context, but it's been tried in Jordan successfully, again, a very small country. But you can see potential there for where these coordinations might work. I'm not seeing it right now in Pakistan.
So I love the focus throughout the presentation on measurement, how do we integrate the messages, how to deliver them, and then how do we assess them, both at the level of intervention scale up, but also these national mixed indicators. And you mentioned, limited ceilings, they're not best, limited, what can we do? So can you go a little bit further and highlight what are the challenges, what are the promising, I know you've been part of some of these conversations, what are kind of lessons learned to improve measurement of ECD, both at the national level as well as these local settings?
So at the national level,
or international.
At the international level, we're really relying on caregiver report, and we're really relying on trained data collectors who probably have 45 minutes to an hour in a household to survey a whole host of things around the child in the first 5 years of life, as well as the context of the family. So within that, child development will get 10 minutes, maybe less. So trying to tease out which are those indicators, what are the most important ones that you'll get that will show sufficient variability and that can be reliably reported on with mothers. As you know, we've been struggling to really get reliable reports on social emotional development in those first 2 years of life. Simply trying to, and also how do we make sure that those indicators are now comparable? How do you compare what is collected in Pakistan with what is collected in Uganda, with what is collected in Serbia or in Bosnia? So I think there are a number of challenges. I think the discussion has started, and that's important, but it's a long process.